So this particular topic is very close to my heart, and Dr. Barun had said, I am just pursuing my PhD in cardiac rehabilitation, and during this phase, I just came to know that the cardiac rehabilitation is in backdrop in our country. It is not so much explored. So to begin with today's presentation, we'll be touching upon about cardiac rehabilitation program in India as well as around the globe. Then what are the goals of cardiac rehabilitation? What are the indications and contraindications of the cardiac rehabilitation? The different phases of cardiac rehabilitation and barriers of the cardiac rehabilitation program in our country. So if we talk about, before moving to the cardiac rehabilitation, if we talk about the state of coronary heart disease all over globally, the CHD and the stroke are the two main causes of mortality around the globe, and India is not, is very similar. Same, the condition is very similar in our country too, where the mortality due to the CHD is very high. And annual number of deaths from the CBD in India is projected to rise from 2.26 million in 1990 to 4.77 million in 2020. And these numbers are, we can say, these are the hospital-based figures. And if we count the figures like the cardiac arrest, which is happening at homes, so these figures are not included in 4.77 million. So you can imagine the magnitude of this, the issue of the mortality which is happening because of cardiovascular diseases in our country. And it has also been reported as the #1 cause of years of life lost due to the premature deaths. Therefore, along with the actual intervention, the primary intervention, that is the medications as well as the PCI and CABG, if the cardiac rehabilitation is supplemented with the traditional approach, it will have a health favoring impact on quality of life. It decreases the morbidity as well as the mortality. And if we, in detail, if we talk about the cardiac rehabilitation, it's an interprofessional intervention. It's a multidisciplinary team approach where the team of medical personnel, the team of group of team members, they want to work together, which comprises of cardiologist, nurses, cardiac nurse, then dietitian, then physiotherapist, and counselor. They all together work for the patient who has just encountered any cardiac illness, that is ischemic heart disease, heart failure, myocardial infarction, or the patient who has undergone any cardiac intervention, that is angioplasty or CVG. For such patients, through the combined efforts, a better outcome normally comes out, and that is called as in the form of cardiac rehabilitation. It helps the patient in a far better way. If we talk about the cardiac rehabilitation around the globe, here you can see this survey was done in collaboration with International Council of Cardiovascular Prevention and Rehabilitation, where it was found that the density of the cardiac rehabilitation is quite high in Western countries compared to the Southeastern countries, where India, very minimal, very few dedicated cardiac rehabilitation centers are existing in our country, especially in government tertiary care hospitals. These numbers are very low. Okay, there are certain literature, the researches I could found on cardiac rehabilitation, where it says that cardiac rehabilitation in India is in very infantry state, and there is a need of approx 33 lakhs of cardiac rehabilitation centers in our country just to cater the needs of cardiac patients. Then a evidence-based review was also carried out by me and Dr. Barun and of course Dr. Anshuman Darwari, where we found that despite the strong need of cardiac rehabilitation in our country, there is no official registry like Western countries that offer the cardiac rehabilitation program. In our country, we do have a Rehabilitation Council of India, but Rehabilitation Council of India do not endorse the cardiac rehabilitation there under domain. So it is very difficult to quantify the number of cardiac rehabilitation centers in our country. To the best estimates, there could be only very few, like 50 such programs they are running in our country so far. By considering the magnitude of cardiovascular disorders, 50 such programs cannot meet the demand of the cardiac patients. So there has to be more cardiac rehabilitation centers in our country. And in same line, and while I was just going through with the literature on cardiac rehabilitation, I could find one of the, the article was there, one of the, where in Pune, in FMC, recently one cardiac rehabilitation center was open. And these are very few, as I said, in very few in numbers in our country. Therefore, the patient needs could not met, and therefore I think the mortality and morbidity is much higher for the patients who just encounter with any cardiac events. If we talk about the literature says if the patient actively participate in cardiac rehabilitation program, their readmission rates and the mortality due to cardiac events are they substantially it is decreased. And if we talk about the another factors like recurrence of the cardiac event, then development of arrhythmias, then readmission rate to the hospital, then post-infarction angina incident, and the left ventricular ejection fraction, this basically improves, and the recurrence, arrhythmias, readmission, and post-infarction incidences as well as the mortality is substantially reduced after enrollment in cardiac rehabilitation program. So what is the goal of cardiac rehabilitation? The main two primary goals are there of cardiac rehabilitation program. The one is psychological goal and another one is physiological goal. So basically the psychological goal, if we say, then, once the person normally experience any cardiac event, they basically feel they also undergo some psychological distress. So the anxiety and depressions are very common phenomena, and these phenomena also been documented in the literature. So many studies also been done in Western world where they have just seen the impact of cardiac rehabilitation on anxiety and depression. And of course, the anxiety and depression is substantially reduced after enrollment in the cardiac rehabilitation program. And there are certain physiological effects are there on cardiac, the physiological effects are also there by the cardiac rehabilitation program. That is, it reduces the weight of the patient. It minimized the BMI also improved. Then patient heart rate, the blood pressure, and the other physiological parameter also improve if the patient enroll and dedicatedly, he just comply with all the instructions of the cardiac rehabilitation program. So of course it will have a it has an impact on the physiological parameters of the patient too. Also, it helps in decreasing the mortality, and it helps in improve the cardiovascular function. So there are certain other goals, like in medical goals, it improves the cardiac function, reduce the risk of sudden death, and relieve the symptoms of breathlessness and angina, and increase the work capacity of the patient. In social goal, patient able to return to the work as soon as possible, and it promote the independence of the activities of daily living. In psychological goal, it restored the self-confidence of the patient, and it relieved the anxiety and depression. Also, it relieved to manage the stress of the patient too. It restored the good sexual health of the patient too once the patient enrolled in the CR program. In behavioral goals, the patient able to quit all forms of smoking, because one of the component of cardiac rehabilitation is smoking cessation and as well as the alcohol cessation. So the patient is able to quit all forms of smoking, patient able to make heart healthy dietary decisions, patient will be able to physically fit, and patient will be able to adhere to the medication regime. In health services goal, it has a direct impact on reduce the medical cost. It also promote the early mobilization and discharge from the hospital, and it also reduce the cardiac related health hospital admissions. Okay, if we talk about the indications and contraindications of the CR, once the patient is enrolled into the CR program, initially these such patients are being reviewed by the cardiologist, and there are certain conditions and the parameters which need to be seen by the cardiologist. Then only the patient's been enrolled in the CR program. So first is stable MI. The patient is having non-ST segment elevation MI can be easily enrolled in the CR program. Then if the patient had undergone any coronary artery bypass surgery, if the patient has undergone any percutaneous coronary intervention, then of course patient had stable angina, stable heart failure, then cardiomyopathy, cardiac transplantation, valve repair and the replacement surgeries, then such patients could be easily enrolled in the cardiac rehabilitation program. There are certain contraindications of the CR program, that is dysarrhythmias. If patient has experiencing any uncontrolled ventricular or atrial dysarrhythmias, then of course such patients has to be, first need to be stabilized with the dysarrhythmias, then only such patients could be enrolled in the cardiac rehabilitation program. Then recent complicated myocardial infarction, third-degree heart block, unstable angina, then acute congestive heart failure, and thrombophlebitis or intracardiac thrombi. So such patients are normally contraindicated to get enrolled into the cardiac rehabilitation program. Okay, so I was talking about it's a group approach. It's a multidisciplinary team approach where it consists of cardiologist, physical therapist, nurse, occupational therapist, nutritionist or dietitian, the psychologist and social worker. Because the cardiac rehabilitation itself has a multi-domain, approach where each team member has a different role to play in the cardiac rehabilitation as a part of the cardiac rehabilitation team. So these are the coming to the components of the cardiac rehabilitation. These are few components of cardiac rehabilitation in which the first one is aerobic exercise training. The exercise is a very primary component of cardiac rehabilitation program where in each phase the patient has to undergo certain form of exercises. Basically the intensity and the duration of the exercises are varies according to the different phases of cardiac rehabilitation program. Then nutritional counseling. And nutritional counseling basically being given by the dietitian. A robust nutritional plan, a diet plan is prepared for the patient, and then close supervision is also being maintained for the the diet plan of the patient by the dietitian. Stress management, the counselor normally have a sessions for the patient for the stress management. Then psychological support being given by the of course the counselor and occupational therapist. Then cardiovascular disease education and medication adherence is being given by the cardiovascular nurse, and tobacco sessions are being taken by again the psychologist and the counselor. And altogether, these all components are being taken care by the cardiac rehabilitation team. Now coming to the phases of cardiac rehabilitation. So as I said, there are 4 phases of cardiac rehabilitations are there. The first phase is in hospital patient period. So once the person experience any cardiac event or undergone any cardiac surgery, patient being admitted for the hospital for at least 8 to 10 days. So this phase normally this particular phase 1 is remains for 10 days, 8 to 10 days. Then phase 2 phase is post discharge or pre-exercise period where the patient get discharged from the hospital, and so certain form of exercises and certain form of instructions are given to the patient to follow during this phase, and this phase normally remains for 2 to 6 weeks. Then third phase is exercise and education program. In this phase, the intensity of the exercises and type of exercises, some vigorous exercises normally included as a part of cardiac rehabilitation program. And the education also being given to the patient about diet, about stress management, alcohol sedation, then of course the weight management. So these education sessions also being taken for the patient. A patient has to dedicatedly need to follow these instructions just to get relief from the particular illness. Then the phase 4 is maintenance phase, where this is called a unsupervised phase, where patient independently can perform these exercises at their home. And if there is a need, the patient can have a telephonic follow-up. So there are mainly 4 phases of cardiac rehabilitation. The first phase is in hospital phase. The second is post-discharge and pre-exercise period. Third is exercise and education program. Fourth one is maintenance phase. We talk about the phase 1 in hospital patient period, where the duration of this phase normally depends on initial diagnosis and severity of the events, and it depends on the policy of the institute. Usually this particular program, this phase normally remains for 1 week. And during this phase, normally the patient undergo for a risk factor assessment and risk stratification. Actually, when patient is being enrolled in the cardiac rehabilitation program, the cardiac rehabilitation team normally they do their own assessment, and that comes under the risk factor assessment or risk stratification. They normally see whether patient will be able to perform these exercises or no, and whether he will be able to follow the instructions or no. So these risk factor assessment and stratification is very important part once the patient is before the patient being enrolled into the cardiac rehabilitation. Then receiving the information regarding their diagnosis, risk factor, medication, work and social issues also being delivered to the patient, so that patient, the cooperation can be expected from the patient once the patient is being taught and explained about that their diagnosis, risk factors, medications and work and social issues. Very important component of phase 1 cardiac rehabilitation is involvement of the family members. So family members has to be involved while delivering the instructions to the patient. Also, the early mobilization is also one of the important component of first phase of cardiac rehabilitation, where the patient is encouraged for the early mobilization. This early mobilization normally started on day 1 or day of surgery even sometimes. So on day 1, the patient is mobilized with the help of assistant, and patient is asked to just have a walk near to the bed and near just uh, near to the particular unit. And later on, the intensity of the mobilization gradually over the period of time it increased. If you talk about the activities which the patient is supposed to be performed, so these activities are classified under the maths classification, that is metabolic equivalent of the task. It's a measure of the an amount of energy which is consumed by the patient by performing the particular activity. So there are various activities which are being classified under different maths. So the patient has to perform the activities which comes under two maths. So activities of very low intensity, passive range of motion exercise, and upper extremity range of and lower extremity range of motion exercise are the one who comes under two mats. And such activities has to be performed by the patient when the patient in coronary care unit. And I think for the 2 to 3 days, patient remains in CCU, and afterwards the patient is shifted to the ward from the CCU. Patient should in this phase, the patient should avoid the isometric and Valsalva maneuvers. The reason is it increases the workload of the heart, it increases the heart rate also. Therefore, such activities should be avoided by the patient. Even the raising of the legs above the level of heart also increase the preload. So such activities should be refrained from in initial phase, in first phase of cardiac rehabilitation. The patient can use some protective chair because it reduces the cardiac output by 10%. And patient can use the bedside commode because it consumes less energy, 3.6 mats versus the bedpan, which consume more 4.7 mats. So the bedside commodes are more preferable than the bedpans in this phase. In subacute phase, patient is transferred from the CCU to the ward, and the activities or the exercise of intensity, it depends on the, as I said, it depends on the mats value, and 3 to 4 mats classified activities should be, it is normally recommended for such patients. And patient also can perform the ROM exercises, but the intensity is normally gradually it is increased. And early ambulation, as I said, that patient should be early ambulated. And when the patient is in initial phase, the patient was ambulating just near to the bed, can go to the corridors and can have a long walks with the help of assistance even. And when the patient is, able to tolerate it, the patient can have a long walks, and in between patient can have rest period. Okay, there is a recommendation for the prescription of exercise in phase 1 of cardiac rehabilitation, and this particular recommendation is given by American College of Sports Medicine, where it says that if the rate of perceived exertion is below 13, which is being measured by Borg breathing scale. So if we are, with the help of the scale, if we are checking the rate of perceived exertion when the patient is performing certain activities, it is coming less than 13, then patient can continue with particular activity. If the rate of perceived exertion is more than 13, that the activity should be stopped and patient could take some the rest of for some time. For the post AMI patients, the heart rate should be below 120 beats per minute or resting heart rate plus 20 beats per minute. So whenever we are just advising the activities for the patient, the exercises for the patient, we have to check the heart rate of the patient, and after the activity again we have to see it, and we have to make sure that the heart rate should not go beyond 120 beats per minute or resting heart rate plus 20 beats per minute. Post surgery patients, again the resting heart rate plus 30 beats per minute should be considered the point where we should stop any further activity if the patient is experiencing the tachycardia, that is resting heart rate plus 30 beats per minute. If the tachycardia is more than that, then of course we have to stop the exercise. And depends on the tolerance level of the patient. The patient remain unsymptomatic, then of course we can continue with the various activities and exercises. The intermittent sessions are being normally carried out by the patient, and intermittent rest also being taken by the patient. And early mobilization, when we talk about the early mobilization, the 3 to 4 times per day, we should mobilize the patient for first 3 days. Okay, the type of exercises which are recommended in phase 1 are rolling in bed. So we can teach the patient how to roll in the bed, the ankle pumping and ankle rotation. So these exercises are normally being taught to the patient when the patient remains in first phase of cardiac rehabilitation, that is in hospital phase. Also the neck flexion and extension, neck stretch, shoulder circles and shoulder shrugs. These are few exercises which can be taught to the patient, and so that the muscle lethargy can be prevented and patient may have a proper circulation. We talk about the post discharge period, the second phase of cardiac rehabilitation. This phase normally starts, it remains for 4 to 6 weeks. And in this phase, the high level of surveillance is normally recommended. The reason is the patient get discharged from the hospital and patients start to perform certain activities at home. Therefore, the patient relatives, the family member need to be taught about how to take the heart rate and how to assess the work rating scale, because the rate of perceived exertion and the heart rate are the main parameters which need to be assessed for the patient. Therefore, the high level of surveillance is very much needed. And if patient feel any, any sign of palpitation, then the chest pain or other symptoms patient experience, then of course it should be noted to the concerned physician, and of course need to contact to the rehabilitation team. The patient, the ECG monitoring is also need to be taken. So in the nearby center, patient can have a regular ECG monitorings, and risk factor modification is very much important part of this phase. So therefore, whatever instructions were given to the patient, they need to follow it very, with a judicious way. And this phase normally, it remains for 4 to 6 weeks. And also this phase focus on returning the patient to the activities of their living and activities of daily living, where they can have their eating, bathing, dressing and toileting and walking for a while. These activities can be, the patient can have, and then the patient can progress their mobility, that is distance and speed. They can keep on increasing the distance as well as the speed of their the activities and exercises. The aerobic exercise prescription in phase 2 of cardiac rehabilitation, and the crux of this phase is that patient has to start their activities with the warm-up phase. Then they need to perform the activity for 30 minutes, and then they need to cool down for 5 minutes. So it's a duration of 30 to 40 minutes. They need to perform their aerobic exercise, and including that is excluding warm-up and the cool down period for 5 minutes. So the patient should start their activity. Before starting their exercise, they have to warm up for the 5 minutes, so that the blood circulation to the muscles is achieved, and then any muscular injury and any injury to the muscles are prevented because of stiffness. And then the actual phase, the 30 minutes of exercise patient can perform, but we have to see for the targeted heart rate during this phase. And then cool down period, again the 5 minutes of cool down period is normally being carried out by the patient. And the type of exercises which can be done in phase 2 are chest stretch, forward arm raise, side arm raise. I'm so sorry, just a minute. Okay, and bilateral upper extremity exercises, then trunk rotation and the leg straightening. So these are a few exercises which are recommended during the phase 2 of cardiac rehabilitation. Okay, coming to the last part of this session, that is barriers to the cardiac rehabilitation. We have seen so far the phase 1 and phase 2 of cardiac rehabilitation, and phase 3 and phase 4 we'll be talking about in the second session. Before that, there are certain barriers to the cardiac rehabilitation, and which we have, normally we have explored these barriers when we were just writing our this review article on the cardiac rehabilitation. And despite we have robust evidences of clinical and cost effectiveness of the cardiac rehabilitation worldwide, but the uptake of cardiac rehabilitation among the patients is 20 to 50%. Already we have very few cardiac rehabilitation centers in our country, but researchers says, the evidences says that the uptake of cardiac rehabilitation is between 20 to 50%. So very few number of patients, they able to complete their entire phases, all phase 4 phases of cardiac rehabilitation program. And most effective way to increase the uptake of the cardiac rehabilitation by the patient is the clinicians or the cardiologists should endorse the cardiac rehabilitation by inviting the patients, by referring the patient to the cardiac rehabilitation centers. And this has been noted and it has been mentioned in various literatures where the main cause of the main cause of poor uptake of cardiac rehabilitation is the endorsement of cardiac rehabilitation by the cardiologist is very low. Normally, the cardiologists, they do not refer the patient to the cardiac rehabilitations. So some other barriers for the cardiac rehabilitations are low socioeconomic status of the patient. So of course, every time the patient cannot, because of low socioeconomic status, patient every time cannot visit to the cardiac rehabilitation center because it needs, the multiple visits to the CR center. Therefore, they normally drop it in between, and the complete all phases of CR could not able to complete. Poor referral rates, as I was telling, that the cardiologists have not endorsed this cardiac rehabilitation program. So therefore, the referral rates are very low, and therefore, the more patient could not be benefited from the CR facilities. Then poor exercise habits. Some patient normally they drop in between because of they do not have habit of the the performing doing the exercises. Therefore, the uptake is low. The lack of transportation, of course, in the state like Uttarakhand, where majority of population they resides in the hilly areas, the lack of transportation for them is a major barrier. No provision of leave from the work for the center-based cardiac rehabilitation. So in majority of population normally work in a corporate sector or private sector where there is no provision of leave for them. So therefore the uptake is very low. The lack of dedicated CR infrastructure. So in beginning only I told you we have very limited cardiac rehabilitation centers in our country. So this lack of CR infrastructure also contribute to the low uptake of CR ability of the uptake of CR in our country. The lack of endorsement by CR by the cardiologist that we just now talked about, and poor social support system by the family, because family also do not give any the importance to the cardiac rehabilitation. They simply believe that the medication can help them and help them to recover from any cardiac event. But in reality, we have seen that if the cardiac rehabilitation is supplemented with the actual intervention, the primary intervention, it can have a health favoring impact on quality of life of the patient, as well as it decrease the mortality. Lack of capacity enhancement and funding. Of course, we have seen. I'm just exploring the cardiac rehabilitation past 4 years. I could not found even a single center who just run any certificate program on cardiac rehabilitation, as well as there is no funding facilities available on cardiac rehabilitation in our country. So these are few the barriers which normally contribute for the poor uptake of cardiac rehabilitation in our country. So for this session, we have just now covered about the cardiac rehabilitation. What is the status of cardiac rehabilitation in our country? What are the goals and the indication and contraindications of the cardiac rehabilitation? Then, of course, the various phases of cardiac rehabilitation we have talked about, and lastly, the various. So that's all from my side for first session. Over to you, Dr. Barun.
Thank you, Dr. Maneesh. Such an exquisite presentation, and you have pointed out all the cardiac barriers very well in the rehabilitation. And we hope that with time, as this topic is picking up, everyone is taking interest. And so centers will come up and will focus more on the cardiac rehabilitation.
Yeah, we hope so. Sure.
A simple advice of arm stretching, leg stretching, and daily walk. At least this should be advised to everyone, reinforced. Thank you very much. And over to Dr. Ankur.
Thank you, Dr. Barun and Mr. Maneesh. I think it's a wonderful talk. I would request Dr. Barun to just see in the chat box if there are some questions from our viewers, we can answer them. So meanwhile, we just shift to session 2. Session 2, we are having cardiac rehabilitation. Now we'll discuss the practical approach and we will have some insight about exactly how it is being done and how it reflects and in the outcomes, and what difference it makes when we use a practical approach. For this, I would like to invite our moderator, Dr. Anshuman Darbari. He is additional professor and head department of CTVS, All India Institute of Medical Science, Rishikesh. Over to Dr. Anshuman, sir.
Very good evening to all. Thank you, Dr. Amkur. My thanks to Director Ma'am